Dear Chairman, thank you for the opportunity to present at EBC 2021. I'm going to show you a case of stent thrombosis from the EBC MAIN trial. So this is a case of a 73-year-old male who's an ex-smoker with a history of hypertension and dyslipidemia. And for symptoms of angina with a positive stress test, he was randomized in January of 2019 to the stepwise provisional arm. So this is the index procedure. So we can see distal left main lesion 011 with this second lesion in the mid circumflex that was deemed to be a separate lesion from the bifurcation. And we can see that there's quite significant calcification at the distal left main, the level of the carina, extending into both circumflex and the LAD. So this is the QCA from the procedure. And we can see that there's quite a long length of lesion in the circumflex, which is the side branch, about 9 millimeters, with the severe part of the stenosis really at the distal left main towards the ostium of the LAD. So because of the calcification, the circumflex and the LAD were pre-treated with Rotablator. And following this, then the circumflex was stented with a 3018 stent in the mid part of the circumflex, so avoiding the bifurcation. And then the ostial part of the circumflex was also pre-dilated. So attention was then turned to the main branch. So the main branch was stented with an Onyx 4022 stent, and this was optimized in the proximal part of the left main with the pot. And here we can see the result in the ostial part of the circumflex after that. Then there's significant stenosis angiographically here, and that was treated with sequential balloon inflation first towards the circumflex and then towards the LAD. And following this, then a final pot was performed. And we can see then the results of the angiogram after this in the final images here. So there's a good result in the main branch. And we can still see there's this residual stenosis at the ostium of the circumflex where we have the geographic miss here, and it's 48% by QCA. So this patient was then discharged on aspirin and clopidogrel, but about 3 weeks later comes back with severe chest pain, is in the hospital or gets to medical attention within 30 minutes with diffuse lateral ST elevation. And you can see here the angiogram first image, we have an occlusion at the ostium of the circumflex with probable thrombus. You can kind of see this filling defect here at the ostium. So it's within 5 millimeters of the stent. So it's a stent thrombosis. So this was first treated with wire and balloon. And then following that, the circumflex was stented with a 3018 stent. And there's final kissing balloons in the LAD circumflex. 30 balloons. So this is the result at the end. We can still, there's probably some thrombus here just at the level of the carina. And the Plavix or clopidogrel at this stage for the discharge was changed to ticagrelor. Now, this patient had an uncomplicated hospitalization after this serious event because he got to medical attention within 30 minutes. LVEF was preserved after this event, and he did well. So I think this case really opens a lot of discussion points for us. So I mean, it's a case of acute subacute stent thrombosis. There's a few points we can raise for this. is it reasonable to consider the mid-circumflex stenosis to be apart from the left main stem bifurcation? There was significant side branch disease for about 9 millimeters. And is that a factor in this? Also, what to do after rotablator? Does that mandate further treatment? Does it mandate a stent for us? And, could imaging play a role in this case? Would it have changed this case? Could it have been an argument for going that extra step in the stepwise provisional approach? So we've seen a case of complex distal left main lesion, calcified lesion, pre-treated with a rotablator. And in such cases where we have complex side branch disease with a relatively long segment of disease, and if we're going to pre-treat with a rota, the geographic miss is important. And should that mandate a stent in this case, particularly when we're talking about the left main and the amount of myocardium that's subtended? And how important is imaging in this particular case? If we decide that we're not going to stent it, do we need to do imaging to actually support that decision? Or is the angiogram in itself enough? So thank you very much for the opportunity to present this case, and look forward to the discussion that it's going to generate.